This is exams from Radiopaedia, and they are free. You can train on them from Radiopaedia. I have to say tibial plateau. No, lateral view, I told you. You should check the AP view to see it is lateral or medial. Okay, don't overcall anything. Let's see. In 10 minutes, we should go through the 30 images and pick around 10 to 12 abnormalities. You should train on this many times. Misplaced chest lines can come, I think, no. But the rule is if you have a 100% sure abnormality in the rabbits, put it down. But it should be very obvious, and you don't need any further investigation or any other views to put it down. Okay? Sometimes they bring budgets or lytic lesions in the bones or anything, or achalasia or anything like that. It should be very clear and no need for further investigation to call it abnormal. Okay? Sometimes, yes, most of time they give you both views, not only one view. Tripod. Okay, let's see if we have one image here, or I will post one on the group. Okay, let's see. This is the pediatric. So I told you 90% the abnormality is buccal fracture. You should train your eyes on smooth cortex like that. So there is no buckling. Okay. This is normal for me. Let's go for the next image. You can see confidently that there is abnormality behind the heart, and there is air fluid level also behind the heart. So you don't need to another view or other investigation to call this X-ray as no abnormal. So it is abnormal, definitely abnormal. You can put down retrocardiac mass or retrocardiac soft tissue shadow or hiatal hernia or posterior mediastinal. All the answers will be correct in the rapid because there is no way for discussion or further investigation. This one is very clear that this line is totally different from this line. The density of this line is totally different from the density of this, and the borders also, or the edges also. Yes, you can write hiatal hernia, no problem in that. So there is a right parietal skull fracture, right parietal bone fracture. Train your eyes. This is your weapon in the exam, that you know the signs and your eyes can pick the signs. This chest radiograph, I will search for the pneumothorax, intestinum, pneumoperitoneum. Then the bones in this age group, I will not comment on the shoulder and acromioclavicular joints, the ribs, and then the lungs, the retrocardiac, the rest of the lung, all of them is normal. So this one is normal. Here, I told you about the sternum. Only if there is a clear depression or fracture here, you can put it a sternal fracture. Oh, and this is normal one. The elbow here, you can see for lateral skull. Can we tell, right? No need to, if you have only lateral, no need to write down, or you can write the mark on the image itself. But if it is AP, you should write right or left. Temporal or parietal? I think it was parietal. Okay. For this image, you can see it is raised, the anterior fat pad triangle, and the posterior fat pad is visible. So this is 100% sure that there is right elbow joint effusion. If there is no fractures, so go confidently to write down only just effusion. This is the shoulder, the glenohumeral, the glenoid and the humeral, the coracoid, the acromion, and the clavicle is aligned with the acromion. So everything here is normal. Should trace every cortex, draw every cortex. For this one, For the free air, I cannot see any free air here or there. For the bones, all the bones are normal. For the lungs, there is here differential density behind the heart. If I draw it for you, let's this is the retrocardiac. It should be homogeneous, but here there is a small triangle of increased density. So it is not homogeneous retrocardiac density, so there is abnormality here. You can put it down retrocardiac opacity, or better to put down left lower loop collapse without abbreviations. Here for the ankle, the edge of the film go down tibia, fibula, and then the talus. This is the normal appearance of the talus. The calcaneum, normal appearance of the calcaneum. The fifth metatarsal base, and the rest of the bones are normal. The lateral cervical X-ray, the C1, C2, C3, C4, C5, C6, C7, all of them are normal and aligned. The mandible. What happened? Please. I will. Sorry for that. Okay. For the mandible and the skull, don't forget also to look for the skull and the prevertebral space. For the radius, the elbows, first you should trace each cortex for the elbow, for the radius, for the ulna olecranon, the distal part of the radius. There is no fractures. The scapholunate, the carpal bones, the metacarpals, all of them are normal. And for the first carpometacarpal joint, also many times there is osteoarthritic changes, and the joint itself has a very wide range of motion. So don't overcall any dislocation here unless it is flying in the sky. Sometimes you can find a fracture in the base of the first metacarpal bone. This one, it is pediatric age group. You can trace each cortex. This is the fourth, this is the fifth, then the phalanges. I think he should bring another view to call if there is a fracture or not. This lucent line here, you should compare it with the other view, the lateral view or another view, to make sure that there is a fracture here, because sometimes there is lucences in the bone due to trabeculations or vascular lines. So don't overcall. Better to be safe and don't overcall anything. For this one, if no other view, so if you are not confident, don't put the abnormality. For me, better to be safe and don't overcall, better than to get the very hard image in the exam. Because in order to get the very hard image, you may overcall 3 or 4 images. So you will lose 4 marks in order to get 1 mark. So better not to overcall anything. Okay. No, the fracture is very lucent line like that. The cortex should be disrupted. Sometimes there is soft tissue swelling, and you have both views. You should look for the fracture in both views. You should train your eyes to get used on the difference between the fracture and the vascular lines or trabecule. For this view, I told you, you cannot see the zygoma very well, so don't overcall it. So, a little bit you can see the orbital floor here, but there is no teardrop or no clear fracture or cortical disruption, so it is normal. This is the normal sutures and the normal vascular lines. Train your eyes on them. Don't forget to look for the mandible. For this lateral thoracic vertebra, only the compression fracture, the vertebra plana, or if there is a lung mass, like that. This is normal, totally normal one. For the adult pelvis, I will start by the sacrum, sacral arcs, then the outer ring. It is clear. Then the inner ring is clear. The obturators rings are clear. Gentle line on both sides. The normal trabeculations, smooth transition between the neck and the shaft. All of these are normal. You can see the skin crease is crossing over the bones. So it is normal. This is the pediatric hand. Check for fractures if there is distal radius buckling or metacarpal fractures or joint dislocation or small fractures of the avulsion fractures. You can find small bony fragments at the bases of the phalanges. So make sure that all of these are normal. For this lateral, there is no side marker, so no need to put down right or left. But it doesn't mean that this image is normal. If it didn't put a side marker, it still could be abnormal. Here you can see clearly that there is distal radius fracture. The distal radius, normal distal radius, should have a line is oblique to the anterior side. Here you can, if we draw it, the distal radius, the line is horizontal or more or less oblique to the ventral, to the dorsal aspect. So it is fracture. You can go back to eagle eye to see more images for these abnormalities. This is the normal mandible. Normal mandible. There is no fractures or anything. This one, as I told you, compression fracture, L5 pars fracture, or sacral fractures. Here, it could come in the vibe that there is sclerosis of the end plates and loss of the joint space. Sometimes on the APV, you can find a paraspinal collection or mass. So you will go for spondylodiscitis and ask for MRI, things like that. But in the rabbits, I think it is very difficult to bring something like that. But again, if you can see a very obvious abnormality, okay, put it down, but it should be very obvious. No need for any other investigation to call this image as abnormal. Here is the thumb, the normal phalanges and the base of the thumb, the pisiform, everything here is normal. I think the end plate was sclerotic due to the discitis. Here you can see very obvious. This one is classic for the exam. This one is very classic for the exam. The clavicle is high up and not articulating with the acromion. Don't overcall subtle changes or very minute changes. Things should be clear like that. There is no articulation. Okay, this is a right acromioclavicular joint injury. Oh, there's a lot of vascular lines, and sutures. All of them are normal. Don't overcall this as fractures. This is the distal tibia and fibula, the anterior calcaneal process, and the cuboid, the less frank, the fifth metatarsal base, stress fractures. I think if we zoom a little bit, you can see a lucent line here in the neck of the second and third metatarsals. Again, train your eyes on the phalanges, the overlapping shadows here and there. They are normal. Cuboid avulsion, if it is so clear that there is a cuboid avulsion, because this area has many normal ossicles, normal variants. It is well corticated and smooth, and the mother bone is smooth also, so it is not a fracture. The last one, and you should have only one fracture, one obvious fracture. So there is no another fracture, no soft tissue density here. Most of the time, cuneiform and cuboids, you are overcalling it. So please be careful and choose only to write down the obvious abnormalities. Here you can see a very evident transverse lucent fracture in the distal radius. So the how can we differentiate between the femoral neck? No need to. The femoral neck is neck. Intertrochanteric is between the trochanters. No overlapping between them. And you can put also femoral neck, no problem. Here the perfect answer is distal radius fracture. You should put down distal or proximal or neck or base. You should be specific for the site. Here the line is parallel to the shaft, so it is apophysis. And the line is transverse to the shaft, so it is fracture. So there is no marker here, so put down fifth metatarsal base fracture. Here for the chest, again, the free air, pneumothorax, pneumomintestinum, pneumoperitoneum, the shoulder, the acromioclavicular, the bones, the ribs, then the lungs, the retrocardiac area, both lungs, everything here is normal. No need to differentiate between green stick and buckle. You can put down only buckle or torus. The green stick is only bending. It will not come, I think it will not come in the lab. The buckle or torus fracture could come. All the fracture rib with callus is normal or abnormal. It will not come. Here you can see the leonate is articulating with the radius and the capitate is dislocated dorsal. So this is a, this, I don't know, this is right or left, or you should see it very clearly if it is right or left and put down the perileonate dislocation. Okay. And make sure from the other image that if there is a fracture or not. Here for the chest, again, we will see the free air, pneumothorax, pneumodiastinum, or pneumoperitoneum. There is a little bit lucency in both apices. So in your normal routine practice, you should zoom for the apex to see if there is a visceral pleural line curved at the apex. It should be curved at the apex. I think maybe there is one here on the left side. If you zoom, you can see it, but you should know the sign and look for it. Visceral pleural line curved at the apex. Okay, and then the rest of lines, free air, the bones, the lungs, everything, every other thing is clear. Hilum, no, this is the normal density of the hilum. You should train your eyes on the normal density. And again, you have only one abnormality in the image, only one. Yes, left pneumothorax mostly. For this one, you can see, search for the free air. There is no free air. The bones of, you have a left distal clavicle fracture. Here one is obvious one. This is the edge of the film, and it is very obvious that there is cortical disruption. Okay, for this one, this density is totally different from the normal densities. This is more dense, more opacified. So you can put down mediastinal lymph node, mediastinal mass. The previous one, there is no, why you mentioned dislocation? Why dislocated? What are the signs? As I told you, we are searching for the signs, and we have a clear abnormality. So ignore anything else. Light bulb only is not a clear sign for posterior shoulder dislocation. It should have at least 2 or 3 signs for posterior shoulder dislocation. Light bulb only could happen on the internal rotation view of the shoulder. And you have a clear abnormality. Ignore anything else. This one, as I told you, the density is more dense, more than the normal soft tissues. And you can put down right paratracheal shadow or mediastinal mass or superior mediastinal mass. All of the answers are normal, but please put down only one answer. Okay, don't put down two or three answers. No need for that. Okay.